Hello, everyone, and welcome to episode 12 of the Decoding AI in Healthcare series. I am Dr. Harshita, and we are honored to have exemplary guests joining us today. Let me introduce our first guest, Dr. Piyush Mathur. Dr. Piyush is an anesthesiologist at Cleveland Clinic, bringing with him over 20 years of clinical experience. As an educator, he has chaired the Postgraduate Education Committee at the Society of Critical Care Medicine and served as the Program Director for the Anesthesiology Critical Care Fellowship Program for over 2 years. Dr. Piyush has been recognized with over 4 innovation awards at the Cleveland Clinic and is the developer of the difficult airway icon and the process for EPIC. Welcome, Dr. Piyush.
Thank you. Thank you for having me here.
Thank you. Next, we have Dr. Avneesh, a thought leader, educator, advisor, and the consultant at the forefront of AI integration in medicine. His expertise spans anesthesiology, critical care, and pain management. He's recognized as the LinkedIn's top voice and is dedicated to advancing AI applications in healthcare through innovatives like MedAI Capsule. Welcome, Dr. Avneesh.
Thank you. Thank you so much. Hello to everyone, and it's nice to be here.
Thank you. And we welcome Dr. Amit Kumar De again, a distinguished physician and diabetologist known for his visionary approach to healthcare innovation through AI entrepreneurship. Dr. Amit's insights have been invaluable in our journey of understanding AI in healthcare. Welcome, Dr. Amit.
Thank you very much, Harshita. Hello and good evening, everyone, to the 12th episode of MedAI podcast, Decoding AI in Healthcare. And it's really been an amazing journey so far for all of us. We started with the basics of artificial intelligence. We went into discussing about how it's going to impact research, data science, and then we started taking up individual specialities. And today we are going to speak about critical care and anesthesia and how the effect of artificial intelligence is going to impact this particular domain and subject. And it's an honor as well as a pleasure for me to host two very distinguished guests from this particular field and domain. Of course, Dr. Piyush Mathur, fantastic work he's doing with his team, collaborating with tech experts and clinicians, building models, and many more things he's doing at Cleveland Clinic. And it's a pleasure to get to know him and learn from him. And of course, my dear friend, Dr. Avneesh, I would say he's one of the most vocal person in India who kind of advocates the strong use of artificial intelligence. And he's a true visionary that looks that AI is going to make a lot of change in the domain of healthcare in the next 20-25 years. So welcome everyone to the 12th episode. And today we're going to take up a very interesting subject, complicated subject. Critical care anesthesia is something which is not something very easy to deal with. A lot of nuances and use cases could be there, but we need to explore that how AI is going to probably help us in simplifying some of them, or if there is some improvements strategy there that AI could bring us in this particular field. So a warm welcome to both of my guests, and let's start with Piyush with the first question. So Piyush, we have seen evolution happening in the domain of AI. We had the learning algorithms, we had deep learning, machine learning being used to the traditional AI, algorithms being used. And then we had the language models and the natural language processing developing over the last 2 to 3 years coming up. In your domain of anesthesia and critical care, Piyush, can you share with us that what would be some very important nuances or use cases that would make significant impact to the practice of this specialty, or things which are being explored to be implemented and has not been implemented yet? What are your thoughts on some of the use cases in anesthesia and critical care, Piyush?
Thank you, Amit. Thank for asking the question, and thank you for having me over here. And truly, this a very exciting time for all of us, because we have been inputting data, but not been able to utilize it in the way that we think we could use it. So it's very exciting that we can do that. And a lot of people believe, well, AI is the future. I used to say that 5 years ago, but I think AI is present now. It's here. It's today. And I want to share some of the real life exciting examples of AI being implemented, because a lot of AI people don't relate to. And I always say the best AI is where you don't have to code anything. The best AI is that is invisible but is helping you. And we are all using AI in real life, right? Whether you're sending emails, whether you're texting, whether you're watching Netflix, whether you're using Uber, you're all using AI. So we're all AI consumers in many ways. And it's a data-driven science. So it's science. It's not black magic or something. So bring it closer to home, which is anesthesiology critical care. So think about the applications which are there in real life implementation. The one that strikes me is echocardiography. Now, echocardiography, when we use it, is something that requires a high amount of training and skills. And in the past many years, there has been a lot of work, research work that has been done on using deep learning methods to interpret the images that are acquired by the echocardiographers or the clinicians. It is also important to be able to direct the echocardiography probe in the right way. It's essentially an ultrasound probe which follows the Doppler principle, so that you can capture these images in the right way. And if you think about some of the real life applications, that these are FDA approved, and these AI algorithms are now embedded in some of the AI devices, and these AI embedded devices for echocardiography are being used at bedside today. And there are numerous publications which show that even novices, people who are not necessarily trained in using a echocardiography device, are able to use it because of AI guidance. And they can get estimations like ejection fraction out of that estimated as good as some of the sonographers or the echocardiographers. Right. So I think about this example as one of the key examples currently in use, because we use these devices every day in anesthesia and in ICU for treating our patients. But think about democratizing this important key skill set. People have to take boards for these exams. There are echocardiography boards for these. But think about if we can make these ultrasound or these echocardiography devices available to all, to even untrained nurses, and they can help capture the images, they can help capture the data and infer the data, then we can be used more meaningfully in treating the patient and not just spending time performing some of these tasks, and thereby democratizing care for this patient. Think about places where you can't have training and education readily available for these things. Now, I'm not saying that you exclude the clinicians. In many circumstances, you will still need the clinicians, you will still need the experts for that. But I think this is a great opportunity where in real life, AI is helping us democratize care.
Fantastic. I mean, that's just one of the nuances you shared, right? I mean, going ahead over the next 1 hour, probably you would give us some more use cases that you're already using or that you're exploring using with the language models. Would love to learn and hear about that as well. So I'll come back to you, Piyush. Let me go to Avneesh now with one question. Avneesh, you and me have been discussing a lot about personalized care, and precision medicine. And in my domain, in metabolic medicine, in diabetes care, we are really exploring this, thick and thin. We're exploring how much we can get customized with the treatment and personalization of therapy and get more behavioral changes in the lifestyle aspect and get more better clinical outcomes. So, Avnish, in your domain of critical care, and having said that, one phase of my life I did spend as an intensivist, the early days of my life, when I was just started to practice. And I know how complex this can get, taking the right decision at the right point of time in the ICU. And you need a lot of data to support that. So, how do you feel, that the use of these AI tools could personalize the practice of anesthesia and critical care? In your thoughts?
Thank you, Dr. Amit. Thank you for having me, and it's really nice to have a chat with such great experts. And the thing that you mentioned is very correct. That the future of medicine that we are moving towards is more of a precision or an individualized medicine. because till now we have been practicing like one size fits all. So what we do usually as anesthetists as well, when a patient comes to us in the pre-surgical time, we see the patient. We try to fix them in certain standard like systems, like whether it is a American Society of Anesthesiologists, class 1, class 2, class 3. That is based on the risk that is expected from the surgery and anesthesia. But what I see with the things like AI and unsupervised learning, I see there are a lot of features which we don't consider while classifying the patients into risk groups. And what happens is that, as we have seen with AI, it uncovers a lot of invisible information, right? Like new phenotypes or maybe some reasons to things that we encounter, but we don't understand that why this patient responded differently to a particular set of treatment. So I see these things becoming more and more explainable and clear in times to come. We will not be classifying patients into just 2 or 3 classes and then making anesthesia or critical care or treatment plans based on that. But we'll be having a very individualized patient class. That is, each patient is a class for himself or herself, and each patient is different. And like optimizing drug delivery, tailoring the treatment to every patient, depending on hundreds or even thousands of parameters which are being gathered in real time, because you see intensive care and anesthesia is a very data intensive branch, just like radiology. Of course, it's not so much image based which work which we do, but we have a lot of numerical data that we encounter on a daily basis, and most of it is structured, which we have to go through the charts and see the monitors and then take our decisions. I see these things becoming more personalized because of application of AI in coming times. This is my view.
Wonderful. So, Piyush, I mean, when we talk about the right use of AI tools in the domain of critical care, we are definitely looking at a lot of data which is going to be structured, which is going to be clean. But also in your domain, what Avneesh just said is quite right, that you also need a real-time dynamic data. That is probably going to be very important. So probably these would be some of the most important pillars or structures, when you are building up a model, just like you are doing. So, from your point of view, when you are going to be exploring the implementation of, say, an AI tool into your practice, what could be the primary challenges that you feel would be coming or is coming right now, that you're kind of facing? And how do you really plan that, we can overcome these challenges and take us forward, with positive viewpoint?
Yeah, no, that's a great question, and there are a lot of challenges. We have written book chapters on these, and there are numerous challenges in this, just like there are in real life. So there are two that I would like to acknowledge, and that I would like to highlight over here. The first one is uh, ensuring that we are validating the correctness of AI, because previously with drugs and devices, it used to require an industry to develop a drug or a device, and you would subsequently undergo these would undergo randomized controlled studies at multiple centers, and then they would be brought in. Now what's happening is, I just need a laptop or I need Google Cloud. There are certain algorithms that are already there. I can modify them and I can create my own model, and I can say like, hey, it works great. How do you know? So I think ensuring that we are responsible, and that's why we are having responsible AI available to our patients is extremely important. That's where validation is extremely important. So there has been a proliferation of all these models. Everybody is these days trying to build a model for a particular task, but that validation before it gets implemented into real life is extremely, extremely important. The second one that I would like to highlight is education, because there is still a real concern, there is still an information gap, there is still a real fear of AI, not just in healthcare, in general too. And the only way to fight fear, in my opinion, is through education, through educating us all, so that we are all understanding and speaking the same language. And that's been our effort with BrainX community, to educate everybody with AI in healthcare. And that's what is great with MedSynapse and MedAI, and what Avneesh is doing, that we are all trying to have a common level of understanding so that fear goes away. That understanding is built. And that's where we can accept it. So I'll give you one example of this, or actually two. So there were two models that were very well validated from very respectable researchers published in journals like Nature. And subsequently, they were tried for implementation, and their output was very good too. But what they found was that only 50% or so of the clinicians were accepting the output for further human in the loop implementation or following that guidance. So why is that so? Why is there that gap? And I think that education will help fill in that gap, will build in that trust. And that's where I go back to the validation piece too. How do we accept any drug device? Or similarly, we should accept AI algorithm. It has to be validated. And that's what we are very, very focused on.
Absolutely. Very important points you made there, that the validation is going to be very important into the acceptance and the application, and then again, the education. So, Avneesh, this is a thing that we all, both of us, keep discussing, that, even in our doctor's AI discussion, we keep on discussing this, that, for the right implementation of an AI model, the right need gap has to be created by the ones who are in the ground zero, that is the clinicians, and then that has to be kind of translated into the right technical language to those AI scientists and the data scientists who are going to come up with the right kind of algorithms, and then again you're going to be validated by the right clinician. And there's got to be a constant association between the two worlds happening. And I think that's what Piyush is doing, that's what you are doing, that's what we are all trying to do, that there has to be a constant marriage happening between the two worlds, and so that we can get the right nuances, the right use cases coming out, addressing the right need gap. So with education, and having said that, we are all working very hard to educate our peer groups. One such example is MedAI podcast. Where do you really see the clinicians play a role in this whole ecosystem, especially in your domain of anesthesia and critical care? What are your thoughts, Atish?
No, definitely, Dr. Amit, you are right that there's a need to create more bridges between the medical and the technological community. But whenever we speak about it, you see, you need a common language. You cannot say that we can talk to each other. I can talk to you in English and you respond to me in another language, and I will understand what you say. So first thing is to develop a basic understanding. I see a lot of work that is being done to take people like into the details of AI, like into coding, into the like deep tech stuff. But there are very few things that help a person to reach from 0 to 1. So that is where my entire focus is right now. Because when I talk to my peers, I realize that they even don't know the basic definitions of AI, machine learning, deep learning, and we are talking to them about RAG and large language models. And so I think that we will reach that stage. But right now, a lot of work has to be done on the foundation side. We need to take people from 0 to 1. There's a lot of hype and fear, and it is, of course, it is masking the logic. So I always say that there are three things. There is ethos, there is pathos, and there is logos. And there has to be a balance in all these three things. So right now, what we see is there's a lot of pathos, there's a lot of emotion, fear of replacement, and fear of automation. But logos, which comes, of course, with education and studying, and the ethos part again has to be built on top. We'll be talking, I think, in this podcast as well about ethics, because no talk is complete without ethics. So all these three should come in balance together. All these three things should be taught to medical professionals right in the medical curriculum. We need to revise some areas, maybe not have a different subject, but to incorporate AI into all the pieces of education that we are providing to medical professionals, because already it is overcrowded, and I think we need to revamp it. I don't think just adding a subject or adding coding or adding something will make much of a difference. So those are my views of how to integrate education into healthcare in an ethical way. That is most important.
Yeah, and also the other aspect is, trying to understand the actual need gap that is there. Now, for example, you as an anesthetist or as a critical care intensivist, or Piyush from his Cleveland clinic would be the right person person to sort of raise those need gaps, which a particular team that is surrounding Piyush at Cleveland Clinic can build on to give him a model that is more specific to his use case, and likewise for you in India. And that's going to be quite different because of the diversity of the healthcare infrastructure that we are working in. So understanding that expenditure, that need gap is so very important, and for that the clinicians need to come on the forefront, understanding the basics of AI. Of course, not the coding, the basics is very important. That's what we are all attempting to sort of percolate to our peer groups, so that they know the basics, they have an understanding, and they can raise their voice in sort of creating the need gaps, with which I think some technical expert can come and help them out in solving the solution. Rather, it should not be other way around, that you have a ready-made solution and you are sort of asked to work on it, which is not at all going to be helping you in your use case. So Piyush, I'm going to come back to you, and we've been talking about generative AI for the last 1.5 years. It's been a revolution happening. We say that this revolution is as comparable to the discovery of the telephone or the internet coming in, and it's a whole new domain that has opened up. And we talk about the language models, the small, the medium, and the large language model. And then you have the proprietorship models, and we have the open source models. And you yourself is working on similar models of this side. And in healthcare as general, Piyush, what do you see are some of the most potential applications, as well as some of the challenges in implementing these language models as a clinical decision support system in general, not just in critical care, in your domain, plus in general?
Yeah, no, I think that's a great question. We are living in very exciting times. You described the telephone and the internet and other things. I tend to think about what happened with ChatGPT as the hello world moment for AI. So if you go back to when Mac was put out there, it ushered in the era of personal computing for every single individual. People started relating to personal computers because prior to that, it used to be IBM mainframes and only the technologists could use it, and you couldn't do personal computing. But Mac said hello world, and that's what Steve Jobs made Mac say to people so that people could relate to it. I think ChatGPT did something similar. It made AI say hello world to people, and people relate to it. People are using it. It's been one of the fastest adopted application. It has spurred other LLMs and LLM development and framework development too. So we are living in very, very exciting times with this. But your question is great about where should these be applied, and I don't think we know the answer to this yet. I think we know some of the problems. I think we know that it can probably be used to solve these problems, but it's still too early. We're still in the discovery phase. So if you think about what large language models can do, they can answer questions, they can summarize things, they can do document information retrieval, and many other tasks like that. What is the best application for that? And I think about, what do clinicians really want? I don't think clinicians necessarily need too much of cognitive or reasoning at this present moment from these. I think what clinicians are asking for is help in fetching the right information, being provided to the right clinician at the right time. That's what they're asking for. And that's where I see the maximal utilization of this. Now, this might be when you're trying to search the information that is buried in documents or patients' history charts, and you're trying to retrieve those. It might be information that might be in different modalities. That might be in X-rays, and then there is some X-ray reports, and you're trying to find that information collectively. I think that information retrieval is one of the key tasks that people are looking for, because there's so much of data coming at us. There's so much different type of data that is coming at us. We're just having a hard time synthesizing it. The other part is inputting that data back into some of these information systems. That's where it is likely to help us. So you think about physician-patient encounters, and many places have adopted EHRs, especially in US and a lot of developed world. But it burns us out, trying to put in that information. So can these large language models make it efficient? There was a recent paper that demonstrated its implementation, came from Kaiser Health. I would highly recommend reading that. And it's shown that promise right now. So can it unburden clinicians and bring them back to the glory of what they were trained for and what their expertise truly needs to be represented in? I think that's the real promise for these large language models for us. But are they ready for all these different tasks? We don't know yet. I think that's where my team, with the BrainX AI Research Lab, a lot of us are working on that. And I'll share some examples as we talk through this. There is a big part of value proposition assessment. So yes, LLMs can do a lot of things, but it comes at a cost. So currently, a lot of residents or trainees are asked to do discharge summaries, and sure, LLMs might be able to replace them. What if I were to tell you it's going to cost you $1 to do each discharge summary? You might say, you know what, let the residents do it. So I think there is that value proposition too that we need to understand. Where will it be best utilized and at what cost? And those are some of the experiments that we're running and do right now.
Yeah, that is fantastic, and I'm going to hear a little more about you on that. But I will go to Avneesh now, and he was talking about while we are talking about large language models, he was also kind of raising his eyebrows when he was talking about the ethics. And Avneesh and myself, we have sort of explored the entire WHO guidelines, which was just recently published, and we summarized that. And for our medical fraternity friends in our Doctors AI community, we summarized that, and that's out there. You can sort of read that. That's kind of a concise 50-page summary of the entire document. I think it's in a 20 odd pages we had summarized it. So Abdish, you've read that document through and through about the ethical use of these large language models. Again, critical care, anesthesia, a lot of dynamic decision makings to be done, to be based on real world data, real world dynamically changing data, and then also a lot of automation happening, just what Piyush was just talking about. And that automation can lead to a lot of automation bias and de-skilling of an intensivist. And we understand that how skill is very important in the domain of the critical care department. So what are your views when you look at, large language models, critical care, and ethics?
So I would say it's not just about anesthesia or critical care. Of course, it's a very critical branch. But
Yeah,
whenever we
as a
talk
whole.
about healthcare as a whole, I think ethics should take the front seat. Healthcare is a different domain. It is where lives of people are involved. And as I said, ethos, pathos, and logos. So ethos is one of the pillars of the tripod. So if you see, one of the major ethical issues with these large language models is the data that is used for training of these models, which are publicly available right now. Like we don't know what data was used, and how, and many of them are closed source. We don't know what goes on behind it. So they are sort of black boxes, right? So if you are directly taking them and applying them to healthcare, there might be problems where the decision, if you're using it in clinical decision support, then you might get some biased decisions. And if you are completely again reliant on those, then again automation bias kicks in, where you might create unintended harm to patients. And that is the first dictum of healthcare, which should be not broken when we apply AI into healthcare. That is, first do no harm. So that is what I say. Other issues, of course, there are issues of liability, because when a medical professional is using these large language models in their workflow, then what is the amount of liability that comes to the harms that are caused due to decisions which are taken uh, by using the LLM output, and whether we are using them ethically by ourselves. Because I have seen a lot of people, medical students, using just AI large language models to generate medical papers, medical essays, and just copying and pasting them, and sometimes even they are putting patient data, sensitive patient data into it, unknowingly, of course. When you educate them about the anonymity and privacy of data, they of course realize it, but by then the damage has already been done. So I think these are big issues, and one of the issues which Piyush highlighted very well is that as we move more and more towards large-scale use of LLMs, they are using up energy. They are drinking water. They are creating environmental issues as well. So we need to keep a side eye on those issues also. Like, it's not that you run queries on LLM and it comes for free. So there should be limited queries, good queries, and efficient use of LLMs. I think these are the ethical issues that we should see moving forward. Of course, job replacement and skilling up and all those are again common to all industries. But specific to healthcare, I would say that trust is a big issue that needs to come into healthcare AI.
Yeah, and I think ethics is much more complicated, and I mean, it's very difficult to sort of explain it in 5 minutes or 10 minutes. It's quite a difficult nuance there. And also, maybe the other aspect, Avnish, that I really feel is the transparency of the model. That is also very important. The labeling, how the model is reaching to a particular output and how it is coming up with this. There shouldn't be any black box there that Piyush keeps talking about. That is also a very important aspect of the ethical thing. And I think it's going to evolve, right? 2024, 2025, if both of you agree, we will probably see a lot of evolution happening in the ethical aspect, in the regulation aspect. With that, the guidelines are probably going to be set in. It's going to be more, I would say, regional. At the same time, it would be global. There would be an amalgamation of both the type of guidelines, which will be sort of affecting the large language model usage in the specific country. And it's probably going to evolve. So we all have to wait and see how that happens. And we just hope that we get to play a major role in sort of shaping the ethical structure of how the AI, LLMs, and generative AI models or any algorithms are going to sort of impact healthcare. Piyush, I'm going to go back to you, and two important things that Avneesh, and I will just take it forward from there. In your domain of critical care and anesthesia, taking the right decision at the right point of time would impact the life and death situation of an individual. So, using a large language model as a clinical decision support system in your domain has to be very precise and very accurate. So, how do we really evaluate a large language model output? You have been working on something called Humanly, Human ELY, and tell us more about it and what are your work you're doing there, and let us know a little bit more.
Yeah, thank you, Amit. And the last year was really an overwhelming time period because all these large language models and their utilization frameworks were coming out. So our team at BrainX AI Research, we started seeing how can we take these AI models like ChatGPT or the versions of GPTs or Llama or other ones and apply them to healthcare for different tasks, whether it's for question answering, whether it's for summarization or something else. One of the challenges that we found when we looked at the output of these large language models, so say you ask a question to this to ChatGPT, or you ask it to summarize a document, is that it'll give you a very nice output. It's very verbose, it's very nicely written, but how do you know that this is accurate? So there are certain technical metrics which have traditionally been used in natural language processing, such as Blue Score or Rouge or other scores. But those are not necessarily geared towards measurement of accuracy, reasoning, comprehension, missingness, and other things for large language model output. But people have been using those because those are the ones that were available right away. And then newer scores or newer methods, technical methods have come out for measuring hallucinations and other issues with large language models. But what we found was that beyond the technical metrics, you still need to do a human evaluation or human validation. That's what you'll see with all the research work that has gone on, especially in healthcare, where that context and that reasoning and missingness is of extreme importance. And that's where we found a huge variability in these assessments. So somebody would look at accuracy, somebody would look at accuracy and missingness, another group would look at accuracy, missingness, hallucination. Not many people are looking at toxicity, so can it carry in toxic language into the output? So we found this variability, and as our team was experimenting with this, we said well, we need to build a better tool to perform human evaluation of these LLM outputs, which needs to align with human values, because that's the purpose. It's supposed to serve human values and supposed to help us. So what we did was to look at what are the traditional different metrics that have been used for human evaluation. We compiled them, we studied them, and we created a tool for ourselves called Humanely, which has 5 key metrics And you can read about it on brainxai.com/humanely. And we said, why don't we make it available to everyone? Since we are going to be using it, why don't we make it available to everyone? So we put it on cloud and we made it available to everyone. We don't store any of the data that you might put in there for yourself. The only data that we store is for our QA purpose. That is only the Likert scale numeric data. So we want to just see what different metrics you are using. And the idea behind that was, let's have one comprehensive, measurable, replicable tool to assess the output of large language models. And this is not just for healthcare, this is for any LLM in general. So you could use it for, say, if you're trying to summarize a newspaper, you're trying to summarize a video, text, or anything, you could use it for anything. So it's agnostic of the domain needs. And as we do our experiments, we are using this to comprehensively assess the output of these large language models. And that aligns our mission and vision and with responsible AI to do it responsibly. We do need tools, and this is our effort in providing these tools to everyone.
Wow, that is fantastic. I mean, it probably is the start of setting up a structure and creating that bridge gap, something that we are all working. And if I can use the term, that this would probably be the right way to set the context to evidence-based, validated, intelligence-driven medicine. You have data, so it's intelligence driven on one side, and we have been conventionally practicing evidence based medicine. And you need to sort of find a way to mix the both with the experience of the clinician coming in somewhere in between to validate the model so that it can do good and not cause any harm. So that is a fantastic structure you're building. Many congratulations to you, Piyush, and your whole team working out there. And we just hope that more and more of our peer group friends find it enlightening to sort of collaborate, join in. And when I say this, I always say when we talk about peer groups, we no longer talk about our clinician friend. We also talk about our friends from the tech world, that they come in and they collaborate, and we come in and we collaborate, and we always see a win-win situation happening and coming out there. Fantastic explanation.
If I may also add, I think when we built this tool, we wanted to be simple for people to use. And what do they typically use for evaluation? They use Likert scale. That is what
Yeah.
they're familiar with. So that's why we
Yes.
built the tool so that it's efficient and it's something that people are familiar with. And that's why it's a call to clinicians to get engaged in ensuring that their expertise is being used the right way to guide responsible AI in healthcare. So if a lot of clinicians don't want to code or they don't want to develop these models, don't want to get into the details or intricacies of some of these models, they should at least help us validate these models, just like we do for drugs and devices,
Absolutely.
and ensure what these models are being developed for are utilized in the right way for our patients.
Absolutely. And just from where you just said that, I mean, we see a lot of chatbots coming in, most of them using a GPT background or a good resource, large language background, coming in as a support patient education tool. That's exactly where you start from. This chatbot needs to be validated by simply using a Likert scoring scale before it's put to use for a particular patient. And that's something that we are also working on, and we will share with you. And that's just fantastic to know. So, Avneesh, you were talking about something called value proposition for generative AI in healthcare. And while we know that it's a fear, the rewarding has to be there, the right focus has to be there in the individual using that particular model. So, how do you define this value proposition for generative AI in healthcare? Can you tell us a little about it?
I would say that the value proposition of generative AI in healthcare, we should keep patient as our North Star. If it is benefiting patient outcomes, benefiting patient care, making quality of healthcare better, then that would be the true value proposition of AI. Some of the things which I see coming in times to maybe next year also is reducing the burden of administrative tasks to a large extent, because that is one of the measurable and highly effective ways in which how generative AI can help in reducing the burden of clinicians, and in turn improve their like as Piyush said, the cognitive load which they are taking on a daily basis. I don't think that those petty administrative tasks should add to that burden of diagnosing, treating, dealing with the patient. I would say, in fact, not just diagnosing and treating. We have to deal with them as human beings. We have to communicate, and that takes a lot of bandwidth. So that can be taken care of by generative AI. After that, of course, as clinical decision support tools, but after validation, as we discussed with clinicians, by clinicians, before being applied into healthcare and not being implemented just as a hammer for nails that are not there. We always discuss this point. That would be another value proposition, how we can assess it. And finally, I would say that personalization of patient care. I think medicine needs to go from like one size fits all to individualized, personalized. If you are giving me a diet plan which I should follow, then I should understand it and it should be customized to me. If you are giving me a treatment plan, it should be tailor made for my situation, my circumstances, and that is where generative AI can help us jump that barrier and to provide that to our patients. So if generative AI can do all these things, then that would be the true value proposition of generative AI.
So patient-centric approach, and that's just the one term that the patient has to be in the center at all focus. That's where the ethics come in. That's where the validation comes in. That's what using the right large language model for the right particular use case or the right application comes in. That's why a good knowledge-based uh, doctor who is versed with the use of these models to choose the right model comes in. A good AI scientist with a good background knowledge of data science and building the model comes in. So I think all this comes in. But having said that, the automation is something that we are all looking at automating the logistics, the administrative task, but at no point we are looking at automating some of the clinical skills of the individual and pushing our fraternity into a state of de-skilling. So that's again a fine line that we sort of have to build and balance, and that's going to be an important part of your value proposition as well, because that's the whole thing around which you are trying to build. So how do you balance this, Piyush? Like, how do you balance between AI-driven decision making and the human touch? That is very important. You've been building humanly, that's going to validate. But in real world application, you have a large language model giving in some inputs to help you with the clinical decision support system, while the doctor has to use his own clinical expertise, his own empathy, his own wisdom, his own experience to match with that and then come out with a decision. How do you balance that, especially in a sensitive life and death situation like critical care?
Yeah, so I think that's an important piece. I think we ourselves will discover that, and I think we ourselves need to be engaged to guide this in implementation phase. So we use electronic health record, and I I and many others spend enormous amount of time fetching information currently from the electronic health record. Is that what we want to do when we are trying to save somebody's life? Or can that query be made contextual and easy and get me the right answer quickly? Uh, I think that is more valuable. As Avneesh said, it's not just about replacing us. It's not about replacing physicians, but can it sift through the tasks that I don't want to do and simplify them? And the tasks that I want to do, then I spend more time on that. Like I want to talk to my patient more. Even simple things like when I'm talking to my patients and providing them a summary, you many times would go for a doctor visit and they give you a bunch of reports and everything after that, and you're trying to read through them and you don't know. And everybody has a different level of education, especially when it comes to healthcare. And you're trying to contextualize that word cancer in there sparks a lot of fear. The terms like mortality sparks a lot of fear. Can it be broken down and contextualize for the patient? That's where can it be helpful. Say if somebody has a particular language that they lean to, can that be translated for them in that language, despite me being challenged as a doctor in that language? I think all those things are where these uh, AI models can help us bring us closer to the patients and not moving us away from the patient. And then the skills that I have, it can augment those skills. That's how I look at it. But I think we're still in the discovery phase of where do we want to apply this, and that's the meaningful and fruitful challenge for us.
Where do we want to apply this and how much do we want to apply this? And for
That's
that,
right.
we need to be very importantly aware of what we are applying. So education is the key. And that's what we all keep talking about, that you have to come out of this wow factor. This is something which I keep telling whenever I keep a talk on AI in any forum. I say you need to come out of this wow factor and ask the how factor. How is this output coming? How is this algorithm working? So how important medical education is. I mean, we have discussed, Avneesh, that probably in the coming decade, we're going to see a paradigm change in which medicine is taught, medicine is perceived, and medicine is practiced. So standing today, 2024, 2025, and we have probably people say that we are reaching a stage of AGI in by 2030, whatever. Okay, standing today with this changes coming in, how do you see the medical education and training programs evolve? So that the next generation clinicians, I mean, just not critical care intensivists or anesthesiologists, but doctors as a whole, they can evolve so that they can augment the use of the right AI tool in their practice to improve their patient care.
Yeah, definitely. So I just had a very nice experience. I just gave a talk last week, and the topic of the conference was future of medicine. And it was such a great feeling to see people from all the generations, like teachers, students, coming together and discussing about it. And they were really excited about the future of medicine and how AI is going to play an important part. And they were willing to learn. A lot of them connected with me during the conference, after the conference. And this was a big topic of like discussion, that how to redesign or revamp the curriculum. Because see, you already know medical education is a long haul. It's not easy. First getting selected for the competitive exams in India, and then going through the grill of medical school, specialization, super specialization. I think it's difficult to include AI as a different vertical or an entire subject or a specialization, and that would defeat the purpose also, because then again we'll be creating more silos. I think the whole purpose of AI as a technology is to break the silos. So I see, like in our books, we used to read that at the end of the chapter there used to be like a short case study or a short snippet, like how this applies to the real world. So I think those snippets should change to how AI can be applied, or how AI can change the thing that we just read in this chapter. In this way, if we include small parts of AI into our entire curriculum, I think that would be a good way to incorporate it. Of course, medical students are willing to learn this technology. I could see a lot of frustration, I would say, because they are trying to learn about it, and there are no sources, or there's no one to teach them about it. Because the teachers are also learning, right? The trainer has to be trained. I think more programs have to be started to train the trainers, take them from 0 to 1. And it should be a two-way approach, like teachers teaching the students and students teaching the teachers, experimenting together, using those tools, not being afraid, developing a safe environment. I would say, like, I could see some students putting patient information into chat GPT, and then when I told them, see, you don't do this, this is wrong. And then at least someone has to tell them, right? They have to be educated how to use it in proper way, ethical way. I think these have to be focused upon. Then I would say that more of no-code tools, which I felt one of the barriers which all students said was that we will have to learn coding, and it will be difficult for us. So I would see more of no-code tools or no-code things, like humanly, like something which can be done right on the go, and people can see that they are involved in AI, in medical AI, and they are making a meaningful contribution to it. I think more of these things have to be promoted in AI. And of course, I would say avoid the shiny object syndrome. Today it is generative AI. I know it's a big thing, but then again, we need to return to the scientific or the academic AI. So that what I would say, and Piyush would agree with me on it, that there's a lot of wow factor, and there's a lot of news and hype and fear in news. But we need to go back to research, proper research, validated research by clinicians, for the clinicians, and patient should be the center of everything, whatever we do in teaching, in clinical practice. And that is my whole point with AI in healthcare. I think we need to educate the clinicians of tomorrow, but tomorrow is coming fast and it is becoming present. That is the problem. We have to adapt fast.
Yeah. So teaching is fun, learning is fun when it's bidirectional. So while the student evolves, the teacher will also have to evolve. As he rightly said, training the trainer, that is also important. And if I can go a step ahead, I would say it has to be three directional now. There has to be the teacher, the student, and the AI. And each of them will be an ecosystem teaching each other and learning from each other. And that's probably how it's going to be the right balance coming up and the right approach to use artificial intelligence in not in a complex but yet so dynamic uh, domain of healthcare, where ethics, decisions, the right approach plays a very key role in determining the outcome in the life of an individual. So fantastic discussions, and I'm going to go to Piyush with one last question, and then we'll have Harshita come back with some questions from our audience. And just to share with both of you, this is kind of viewed across many countries in Southeast Asia and Middle East, and also in the US, Piyush, and also from India, of course. And some of our viewers have been constantly asking us a lot of questions. So we'll come back to that. But Piyush, tell us, how do you see the future of AI tools, language models, machine learning, computer vision, deep learning, making a positive impact in your domain of anesthesia and critical care? I mean, are we going to see a large language model guiding the sepsis guidelines? Are we going to see a language model guiding the infusion rate of the inotropes in the ICU? Are we seeing some automation there coming? How do you see the future in real use case applications?
Yeah, that's a great question. And I think we're still in the discovery phase of that. We're still trying to find out, what's validated, what can be used. I think one of the common things related to that I get asked is, well, one is the black box factor, and the second is, well, it cannot be generalized. And my question to many of those is like, okay, how many of you know how metoprolol was built? And you still use it. Why? Because it was validated in various different patient
Yes.
populations. And then people ask about, well, what about generalizability? This model doesn't work for me. Yeah, that is true, because just like in healthcare, there is not just one beta blocker. There are like at least 50 beta blockers, and you don't prescribe the same beta blocker to everyone. There, we will find out which model works for which group of patients. Well, what's most exciting for me is not about the models, is what Avneesh said. The excitement is that people are excited about this new technology. They want to learn about it. They want to use it. They want to validate it, and they want to help their patients. That is the future. That is the most exciting part of it. And I think that's where these community efforts are extremely important, like MedSynapse, like how you are leading this, Amit, how Avneesh is leading this. We need to create different groups of people with common understanding, common language, and a common purpose that we already have. We all want to serve our patients, we want to help them. We also want to unburden the clinicians in appropriate delivery of care. And that's what is exciting to me, that I have been spending so much time trying to retrieve information. I've been spending so much time trying to import information. I'm tired, I'm exhausted. I just want to talk to my patient and want to help them. And that's where I see the best future of this.
The intent is right, and it all starts with the curiosity. And once you're curious enough to learn and explore, I can still use the word explore, because all three of us here are still exploring each day the nuances and the uses of artificial intelligence. And then you start adapting to the changes, and how good you adapt, how quickly you adapt, and you make the best application, the best use case of the scenario goes on to determine how effective that particular adjunct tool is going to be in your practice. And as I keep saying, that we all need to keep on exploring. But fantastic discussions there from Piyush, Avneesh, a lot of enlightening learning for me as well on what's happening in the world of critical care and anesthesia, and fantastic work Piyush is doing, Avneesh is doing at BrainXI, especially with creating a model like Humanly, where the validation process can be structured, and that's so important from where we stand today. Harshita, can you come back with some questions from our audience, for our two experts?
Yes, we have received questions from our audience, and some of these questions have already been thoroughly addressed during the discussion. However, there's one question which we can take. So, are there any limitations to the integration of AI technologies into existing critical care and anesthesia workflows? And how can these be addressed?
Piyush, you want to take that?
Yeah, I think the biggest limitation is us. It is us, which is the biggest limitation factor, because a lot of people think that these once you build the model, and even if you validate it, you can just implement it. Well, that's not how it works, because you have to think about what does that implementation take. The implementation takes that implementation science part of that. So you have to do it with that scientific approach and scientific background. The implementation requires knowledge on part of our IT teams to implement it. And it's not just about one-time implementation. It's also something called ML ops, or machine learning ops, or LLM ops, which is how do you monitor that your implementation has gone well, and how do you monitor that it's working later on. All these challenges are for us. All these problems are for us to solve. I think the tools exist to quite an extent. I think the technology exists to quite an extent. I think the limitation is primarily us in knowing how do we use this in the right way, and how do we find the right people to help us in integration and implementation of these technologies. A lot of us are building a lot of fantastic models, but when you go to implement them in electronic health record, mobile devices, or other places, you realize it's not just about the AI algorithm. It's also about defining the value proposition, just like Avneesh said. It also is also about uh, making sure that it gets implemented so that people are receiving that information in the right way. So I've been working with another partner, British partner, Dr. Maheshwari, who launched Rouge. It's a personal electronic health record application, fantastic application, uses AI, and it is providing you with meaningful information right in your hands. Those are the kind of examples that we need to see in implementation of these, and how do you overcome some of these technical issues or human adoption issues. So the challenge is and limitation is us, in my opinion.
Yeah, true. The challenge is us, and that's where it has to start with us. We have to start educating ourselves. We have to start learning. We have to start becoming AI literate. And the more we use the word literate, we find that we are in an ocean where we still don't know what's there. And every day we are learning. Avneesh, myself, Piyush, we are still exploring about all the developments that's happening. But still, having said that, I think with the little knowledge that we have, we can take things forward. Piyush is taking his effort through the BrainXI platform, educating peer groups, creating structured validation processes, and creating a fantastic platform where clinicians can collaborate with the technology experts in building the right use case model for the right application. Avnish is doing a lot in the domain of medical education, and I think he is going to tell us about one of the workshop that Avnish ourselves that we have all planned through the MedSynapse platform for some of our peer groups back here in India, Middle East, and Southeast Asia. Avnish, you want to tell us about our workshop?
Yeah, definitely. It's an exciting thing that we're trying to do. And it's all based on the feedback that we receive from people that we talk to. And whenever I talk to my fellow clinicians, so there's a big barrier that they have very little material which is hands-on, and which tells them in live workshop way how to use these tools like ChatGPT, Perplexity, Claude. Um I think yeah, a lot of courses. There are a lot of theoretical courses, a lot of videos, a lot of podcasts and all which are happening around how to use AI. But someone to show, to demonstrate how to do it on their real world use cases, which are specific to the medical professionals and customized, like how to write a research paper, how to create content for yourself on social media, how to use it in clinical decision. So, three of us, Dr. Amit, Dr. Om, and myself, we have sat down and we figured out a way to do this is to go for a live workshop, which is a comprehensive 4 to 5 hour workshop with a complete agenda with the different modules, and we progress starting right from what is AI basics, of course, not too much of theory, and then we move on to the practical applications of AI for medical professionals. So this workshop we are conducting on the 18th of February this month. That is our inaugural workshop, and we have got a very good response. A lot of people have been expressing interest, and I would encourage any medical professional who is still contemplating whether to use or how to use AI and confused, like maybe having information bombardment, information overload. Just go for this workshop, have a look at it, have a look at the agenda, look at if it provides value to you, and join it, I would say. And we would be really happy to help you navigate this uncharted sea. As Dr. Amit and Piyush told all throughout the talk, that it's a very new field. We are in discovery phase. Every one of us is discovering. I would not say that we are perfect and we will teach you everything which is there out there, but we will give you a simple pathway or a simple map to follow and build upon. We'll give you a foundation. That is the whole purpose of our workshop. And there's a brochure. I think the team of MedSynapse will share it. And I really encourage all of you who are really interested. And soon it is not going to be a matter of interest. It's going to be like you have to learn about it. See, these tools are going to affect us. So the earlier you do it, you have an early starter advantage. So go for it and come to the workshop, and we'll be happy to help you with our knowledge.
Yeah, most people keep asking us, where do I start with AI? For some of us, I mean, Piyush started probably many years back. I started exploring AI since 2018, and we were in an ocean. We were like, where to start? Where do I start reading? What is the right book I start reading? I still remember the first book I read was, of course, Dr. Eric Topol, Deep Medicine. That was the first book that kind of inspired me to sort of read about AI. But then it's a journey. So workshop like this will probably help you, give us some structure, give us some foundation, some real use cases, how you can apply. Harshita, you want to tell our audience how they can register and where they can find the link to register for the podcast for this particular workshop that we're planning on February 18th?
Yes, I have dropped the link on the comment section, so they can find it there.
Fantastic. And so we had a fantastic discussion today. And once again, I really thank Piyush having spent some time with us out of his busy schedule, both as a clinician and now, of course, as an AI expert, spending so much time with a team of researchers in his research lab, working on building something which is invaluable. Invaluable not just to his domain of critical care and anesthesia, but I would say invaluable to this whole domain of medical AI. And I think this is going to be a domain that we will all explore, and the contribution that each one of us makes, somebody like Piyush makes, it's going to be invaluable in setting the right stage how medicine is going to evolve in the next 20 or 30 years. And of course, Avneesh, thank you very much, Piyush, Avneesh, for joining us. And would love to have you back again, maybe sometime soon around the clock. We're going to have another discussion, part 2 on AI in critical care and anesthesia. And maybe that time you're going to come back and tell us what are the newer developments have happened and some of the newer models that you would have built that your fellow colleagues are using. Thank you very much for joining in with this interactive discussion. I now hand it back to Harshita for closing the session.
Thank you. As we draw the curtains on this remarkable session, a big thank you to our distinguished guests, Dr. Piyush, Dr. Amit, and Dr. Avneesh, for sharing your valuable insights. And to our esteemed audience, we also want to express our gratitude for joining us today. Before we say goodbye, I encourage all healthcare professionals to explore the enriching opportunities available on our MedSynapse platform. It's a unique space where you can engage in meaningful discussions, connect with esteemed medical professionals, and contribute to the continual progress of healthcare. Until then, stay curious, stay informed. Thank you. Goodbye.